And first we're going to be looking at the emerging role of the PCN dietitian. And I'm aware that many calls for investment in healthcare professionals, including media articles over the years, just refer to more doctors and nurses, and it's always been a bugbear of mine. And then I heard Jeremy Hunt, for the first time as the Minister for Health, refer to other members of the healthcare team, and we still didn't quite get a mention under Jeremy Hunt's reign as such. But in the 10-year plan for the NHS, we were mentioned once, dietitian was mentioned once, it was spelt incorrectly, and it was mentioned in the context of training others, but not all of those other wonderful skills that we've heard about this morning, and we're going to hear more about this afternoon, including from our first presenter, Kayennat. One of the struggles in expanding the role of the dietitians when I've been talking to GPs about why aren't you referring to dietitians in the community is we haven't got the money. And for me, the Royal Pharmaceutical Society really sort of did some groundwork really to change how healthcare is delivered in the community. And I think it was around 2015. They put together a very effective campaign showing how pharmacists could save GP time, save money, and actually address the GP crisis. And I think that was a real springboard and quite pivotal for the other professions. And it was great to see in 2015 the British Dietetic Association really embrace the agenda coming forward to begin to scope some work out to look at the future dietitian and the future of our profession, and looking at embedding us more strongly in the primary care team. And therefore, I'm delighted that we're joined this afternoon by one of these new and emerging dietitians, Kayennat Toofany. Kayennat works as a specialist primary care network dietitian based in Dudley in the primary care network, and describes herself as an expert generalist. She's a clinical lead for PCN dietitians in the Dudley Borough. And as a PCN dietitian, we're no doubt going to hear from her how her role has evolved to include a focus on frailty, but she also sees patients of all ages and for a plethora of conditions that are common in primary care, often take up much GP time, but are much better managed by a dietitian, I would argue, including cow's milk allergy, weight management, IBS, end-of-life nutrition, and management of frail elderly people, often many of whom have multi-morbidities, and they don't just need teasing out one diet, but the complexity of a number of dietary messages that are probably totally confusing on the receiving end for those patients. So if you're looking for a change and a move into primary care, then look no further, as I hope that Kayennat, and I'm sure she will motivate you to consider a future role in PCN dietetics. Thank you very much, Kayennat. Okay.
Thank you. Hi everyone, my name is Kayennat and I'm a dietitian in the primary care networks in Dudley, and today I'll be talking about my journey. Is there any PCN dietitians in the audience today? I've got a few, two, yeah. Is there anyone who's training to become a first contact practitioner dietitian? Okay, that's fine, thank you. So I'll talk about the primary care networks today and what they are, the additional roles reimbursement scheme, what PCN dietitians do, and the difference between community dietitians, PCN dietitians, and first contact practitioner dietitians, and then my role as a PCN dietitian in Dudley, and then some learnings to go with that. Primary care networks, so they're popping up everywhere. They essentially are a very important part of the NHS long-term plan, and effectively the point is to bring general practice together to provide better patient access and care at a larger scale. There is a number of them across England, not UK. So there's 1,300 PCNs at the moment in England, and they roughly cover 50,000 patients each. It's not mandatory to join a primary care network. However, if your surgery does join one of these networks, then there is additional funding to kind of help support patient services. And the purpose of this is to actually provide services closer to home, reduce waiting time, and have a more proactive approach rather than a reactive approach, which we've heard today is quite important. And we want to also then identify patients who could benefit from an NDT approach to provide holistic care. And it's actually a shift in mentality. So looking at what matters to you as a patient as opposed to what's the matter with you. And the benefits of this, the funding from the additional roles reimbursement scheme is that actually a lot of the roles are non-clinical. So we are acknowledging and actually putting the correct people in place to help support people holistically through their kind of medical journey and not just looking at, what medication can we give you or, what the doctor needs to do. If you're part of a PCN, there's actually a lot of money to be accessed to kind of help support these services. So there's roughly around 1.8 billion pounds available to PCNs in England. And if you want to have some of these additional staff that I'll talk about in a minute, there's extra funding for that. So around 891 million pounds for the extra staff to hire to kind of help deliver these services. So the PCN, one of the main source of funding comes from this additional roles reimbursement scheme. And like I said, there's about 891 million pounds for this to kind of hire staff, which includes dietitians, but also include clinical pharmacists, physician associates, occupational therapists, social prescribing link workers, also first contact practitioner physiotherapists, health coaches, care coordinators, and there's a few other ones that I've not mentioned here. But the role of the funding is also to help reduce some of that burden on GPs, and especially in Dudley, there was a small-scale study that was done over a period of time when it was realised that the patients seeking GP appointments, up to 90% of them were for non-clinical needs and only 10% were for clinical needs. So I'm very lucky that in my PCN that we have access to all of these roles mentioned here to kind of help support the patient holistically. And it is here to provide an additional service. So for patients who would not traditionally be seen by other services, it's not here to replace or support established commission services. PCN Dietitian, so what do we do? Well, here I had written that we work at an advanced level of clinical practice, but after meeting everyone today in the talks, I'm going to have to rethink that. We're not here to replace established services. We are here to provide an additional role, and I think a lot of services have become quite, they expected that PCN dietitian will help relieve some of that burden on their workload due to lack of staffing or due to lack of funding. However, it is here to help support the PCN and the GP surgeries and the patient, and not to help support other services that are commissioned. There is a lot of independent work, so you're not working as part of a dietetic team. However, you do work as part of really good MDT that are based in the primary care. In some areas, PCN dietitians are providing traditional community dietetics because of a lack of access or funding of those services. And the beauty of it is that it is tailored to the need of your PCN, whatever that may be. So for some people, they are doing a very traditional kind of, diabetes role or frailty role. And that is what's nice about the role, is that it can be whatever your PCN needs. And if that need changes, then your practice can change with that. And there's not as much red tape to kind of go through. It is very much based on the PCN needs. So what are the key differences? So it's important to remember that we're all here to provide holistic care for looking after a patient's nutrition. So all dietitians do this, irrespective of where you work. However, there are some key differences. In community or outpatient dietitian, that service must be commissioned and there must be funding for it in place. There must be a referral pathway. Often referral criteria can be quite strict, and this is often due to capacity or lack of funding. There are often long waiting times before patients are seen. So in my area, the waiting times are 4 months at the moment for a new appointment. Reviews are very set in stone almost, so every 3 to 6 months, depending on what your kind of service has outlined. The GP must action any prescription request, and any onwards referral usually have to go back through the GP for them to kind of initiate. As a PCN dietitian, my referral pathway is whatever the PCN needs of me. Patients can access through the GP surgery like they would their doctor. Their assessment and treatment and review can be done sooner, and for me it's very much based on the patient's need. So I have some patients that I see once a week, some once a month, some once every 3 months. But the patient can initiate an earlier appointment if they feel the need changes. I can also request prescriptions directly from the GP, and I have access to the PCN-wide MDT, and it's easier to refer because I'm referring from the surgery, so I no longer have to utilize the GP as a care coordinator, and they can be left to use their clinical skill to actually manage clinical conditions. Now, if you're doing a first contact practitioner role, it's effectively a very advanced level of clinical scope that you're working in. So you're working at level 7 clinically, which is different to the band 7. So the band 7 is how much we get paid, but the level 7 is, a master's level. and you're working across one pillar with an acknowledgement of the 4 pillars. So if you were going to become an advanced care practitioner, for example, you would be working across 4 pillars of clinical practice, leadership, management, and education and research, whereas in a FCP role, you're only working as one of the pillars with an awareness of the other 3. It is a diagnostic role in an area of your expertise, and the purpose is to assess and manage undifferentiated and undiagnosed conditions. So it is a diagnostic role as opposed to a treatment role. So how does that work in practice? So a patient comes, after surgery for help, they have new bloating, they've got diarrhea, constipation, and they have abdominal pain. Traditionally, they would contact the surgery and they would see a GP. However, if this is within your area of expertise and as an FCP dietitian, then they would see you instead of a GP. You would then be able to do the screening, the investigation, the diagnosis. You would also be able to do the management. You would review that plan, see whether it was working, and you would then do an onwards referral to community or hospital dietetic if needed to. So you're not meant to technically have a caseload, but I do know that some people who are doing this role are doing this as a split part of their contract. So they're doing an FCP role for 1 or 2 days a week, and then managing that caseload of patients as a traditional dietetics for the rest of the week because of a lack of access or barriers to referring patient onwards to other teams. So this is something that we're not doing in Dudley because it's not a priority at the moment for our PCN, and we are waiting to kind of see how the FCP physiotherapist, podiatrist, and paramedic role develop over the next 12 months before we see whether it's something that we're going to take on board. And this is done under the clinical supervision of an GP, so you're not on your own managing all of this. You will have a GP that you will have access to for help and support, and they will be reviewing your caseload. So it sounds scary, but there is a lot of support out there. The BDA has got a very brilliant roadmap, actually. If anybody was interested in this role, then the roadmap is a great place to start. So in Dudley, we have 6 PCNs, and each PCN roughly has around 50,000 patients. We have got a high amount of this additional roles reimbursement scheme staff. So we actually have every single one that is on the funding, and in my PCN, I have at least one of every single one of those additional roles. So quite lucky. Now, you can see here we've got mental health nurses, nursing associates, pharmacy technicians, occupational therapists, health and wellbeing coaches, paramedic care coordinators, and social prescribing link workers. This really allows us to look at the patient holistically and be able to kind of, find out what their unmet need is and then meet that need in a way. And hopefully, amongst all of this profession, one of us will be able to meet those needs. Now, you might be wondering what's the criteria to see your PCN dietitian. In my area, we don't have one, so we have no criteria at all. Does that sound scary? So, what does it mean to have a service with no referral criteria? Along with the no criteria, we have no form. The reason for this is because we found that there was a lot of barriers to accessing dietetics. Forms were long, uncomplicated. It often had repeating information. We also found from talking to the GPs and surgeries that they didn't have enough time to fill out the forms to a good quality. Often forms are being rejected with unclear reasons why. The doctors didn't really like the must. They didn't have the time to kind of fill it out, and the way it's set up in primary care is that it's an additional step that you need to do. It's not embedded within our clinical systems, so it was an additional step. And often we found that, that I personally, I like the most. I think it's a great screening tool, but I do find that it's increasingly being used as a way of rejecting referral, and as opposed to actually screening for people who are maybe malnourished. And we do know that, the most doesn't really capture things like sarcopenia, for example, especially if you're overweight or obese. And for some of my population groups, so people with COPD or Parkinson, there's often very gradual but slow weight loss that doesn't actually trigger a muscle of 1 for a number of years, and then the weight suddenly drops, and then it's kind of too late at that point to really intervene. So it does allow us, if a doctor refers to me and say, oh, the patient's been losing weight, I will pick up that referral and I will go through, their clinical history. I will go through the entire note, see what the weight loss trend has been like over the past 5 years, 10 years, and then I will take that patient on board and we will put a plan in place to stop that weight from deteriorating further. And often by the time a patient's muscle score is 2, 3, or 4, it's often too late to kind of reverse it back to like a 1 or a 0 if they've got, conditions that have got increased nutritional requirements like COPD. So you might be wondering, does this not increase the number of inappropriate referrals? What do people think? Yeah? No? Okay. So I've never liked the word inappropriate referral. I believe as a dietitian, it's my role to assess whether a referral is appropriate or inappropriate based on a nutritional assessment of a patient and not based on what's been filled on a form or not been put on the form, which is how we traditionally work. So I'm going to go through a little referral, and I want people to let me know whether they would accept this referral. So a 16-year-old patient says she can't eat many foods and has issues with fruits and veg and meat. Her weight is in the healthy range, and she was diagnosed with chronic fatigue syndrome last year. Mom wants a referral to a nutritionist, please see. So this was the referral that was sent to me by the GP. Who here would accept this referral? Okay. Would this technically meet your referral criteria for your service that you work? Or would you accept it on gut feeling? Yeah. So this referral was actually rejected, and the patient was sent the BDA chronic fatigue food fact sheet in the post to manage, and then it came my way. So I saw the patient, had a chat. She had a food list of one food. So she only ate potatoes. She could tolerate potatoes in any shape, size, form, but that was all she ate for the last at least 7 years of her life. So she was at severe risk of malnutrition, and actually it turned out she had undiagnosed ARFID that was related to childhood trauma, which came through while we were talking about what was causing her to only be able to eat this one particular kind of food. And this is the kind of patient that when we hear in the news, a few years ago there was a child who turned blind because of severe malnutrition, basically ARFID. So this is the kind of patient that would get missed out usually because they're not being seen by the correct person, they're not being assessed by the correct person. So I'm not trained to treat ARFID, it's an eating disorder. However, I do recognize it, and I put her on a multivitamin and mineral supplement, and I referred her to the eating disorder service. And she's actually been seen by that since, and she's been going to private therapy because while talking through with her, we realized it actually was related to trauma as opposed to anything else. So she's been discussing her trauma in therapy, and she's actually managing 3 meals at the moment, and her preferred food list has gone from 1 to 50. So, yeah. So who else are my patients as a PCN dietitian? So I actually see everybody from babies to people at the end of their lives. I see things like helmet protein allergy. I do fussy eating. I treat malnutrition. I also do weight management, pre-diabetes, type 2 diabetes advice. I also work with people who've got diverticulosis, constipation or diarrhea. IBS is a big one. I also work with people with end of life. And I also work with anyone anyone in my PCN field need a dietitian. So I will always assess a patient, and then if there's another service out there that would better meet that patient's needs, I will refer them on. But if they would benefit from being under me, then I would keep them on my caseload. And as part of my role, I also work as part of a frailty MDT, and we've recently kind of rebranded to be a well-being MDT to kind of allow more patients to access our service. So our frailty MDT, so this is what our kind of setup is. So when it was frailty only, we only saw patients who were diagnosed frailty and over the age of 65, and they would come in to us. They could initiate a self-referral. They could have come to the GP, and the GP sent them our way. They could have come from other members of the surgery, so the receptionist, for example. We also work closely with the clinical pharmacist and then community physio and speech therapist. And then we also link in once a week with intermediate care team. So we actually meet with social services every week. We meet with the community nurses. We meet with the council. We meet with the safeguard team every single week to discuss patients on our caseload. It's also well attended by the GPs from every surgery to discuss their patients and the specialist nurse. And then we also have a list from the hospital where they will send us a list of everyone who's been discharged that week who may require additional support to kind of continue them to stay at home and to reduce the risk of failed admission, of a failed discharge. So it's very well established. And any patients, so now because we now see anyone with any additional needs, so at baseline we screen for malnutrition, their swallowing, we look at their bowels, we assess for frailty using the clinical frailty score, we look at their independence and confidence, how are they managing at home, do they require equipment, for example, are they at risk of falls, or have they had a fall in the last 12 months, do they have additional care needs, and do they have any social or emotional needs. And within our team, we can manage that usually, or we can initiate onwards referral to the appropriate service to kind of help manage. I'm going to go through a case study just to kind of demonstrate the depth of what we do as a frailty MDT. So this is actually an ad hoc encounter with a patient that we met at the patient participation group for the surgery, and she was having a panic attack. So we booked her into our clinic, and then we noticed that she lacked confidence. She had numerous issues and was having panic attacks regularly, and she had chronic stress. She was visually impaired and struggled with her daily living. She couldn't read her hospital letters, for example, so therefore she was getting a lot of DMA letters that was coming to us. She was lonely. She had no family support. She was isolated. She was financially struggling and couldn't afford the taxi to get to appointments and back, or even to see the surgery. She needed advice on food and nutrition, and she was pre-diabetic, and she was really worried about that. However, that was the least of her problems. She also had frailty and mobility issues. She was vulnerable and didn't have smoke alarms in the house. She had a fall in the last 3 months, and she was really scared of falling again. And she was really scared of not being able to access help if she had an emergency or if she fell again. She also had difficulty dressing her lower self. So this is actually the kind of patient that usually presents at hospital in an acute setting, being found, lying in a pool of urine for 3 days with a broken hip. And neighbours are concerned because they've not seen her for 3 days, and they've called the ambulance or the police. So that's the background of those patient groups. And when I worked in acute, I never truly understood the background of those patients and wondered how can no one notice this patient is missing. But this is how it happens. So with this patient, we actually referred her on to talking therapies as well as a listening and guidance counsellor to kind of help improve her confidence and reduce her panic attacks, giving her coping strategies. The social prescribing team got involved to kind of help her access befriending services. She didn't want anyone to come home to see her because of COVID, but she was happy to receive befriending telephone calls. The team also got involved with the hospital to ask for larger print letters to be sent so she could read the letters. But also we gave her a care coordinator, so whenever that letter would come in for her, the care coordinator would call her up, read the letter, make sure she understood. For her financial struggles, she actually was entitled to attendance allowance, but didn't know about it, so we helped her fill the form out. Advice on nutrition and food, the pre-diabetes was not a concern for me, the frailty was, and she actually was sarcopenic, so we gave her advice on high protein diet. She was put on a supplement, and I referred her onwards to the physiotherapy service for her sarcopenia. And then the OT arranged for smoke alarms to be put in for free for her house because of the service that we have through our fire service in Dudley. And there was hand grab rails that was placed in the house. And she was also actually given a panic alarm so she could call for help if she had one of those falls. So we're really, hopefully that demonstrates actually the depth. What we do with the frailty or well-being MDT is we're looking at a person in depth to kind of help address the issues. And the point of our MDT is actually we want to stop people becoming housebound, and those who are housebound, we want to stop them from becoming bedbound. And ultimately, that is going to save money because it's less access to services, but it's going to have a really improved quality of life for patients, which is really important to us. So some feedback. So the patient said she was extremely grateful for our support and advisors, but she was overwhelmed with gratitude for the support that was given to her. She stated she wished she had our input months ago as she had felt so down and lonely. So this is the kind of verbal feedback that we get. But I know everyone talks about outcomes and they all want to see, right, what the numbers are, what the figures are. So we also have measurable outcomes that we keep a track of. So for her, we looked at the frailty score. When we met her, it was a 5, and it was likely to increase very rapidly to a 6 or a 7. And her current frailty score is a 3. And it's not often that we hear frailty scores actually reversing. It usually deteriorates, and once on that path, it can't be reversed. But actually, frailty is a balance. We can actually go the other way with the correct support for patients in place. And we looked at her number of GP appointments. So are we actually reducing the burden on GPs like we're meant to as part of our role? And actually, so she had 4 appointments for her panic attacks and anxiety in 7 months. And then after our intervention, she's had 0 appointments for her panic attacks and anxiety with the GP. So we've definitely reduced this person's access to the GP when it's not needed, because her unmet need is being met elsewhere by different people who are better suited to provide that service. And then another way that we've recently started collecting outcomes is by asking patients to fill out self-reporting questions on their support, activity, mood, falls, mobility, daily living and nutrition. So we collected before and then after. So this bottom chart here is the before. One is the worst that it could be and a 10 is the best that it could be. And then we collect the after our intervention. So hopefully you can see here that actually every single one of those, the patient reports that they've had an improvement in every single one of those outcomes that we've looked at. So that's another way of measuring outcomes that we do. And then we looked at a few of our patients who came through the MDT to see us, and we collected their number of appointments 6 months before they had our intervention and 6 months after they had our intervention. So the bottom line is just patient details, they're anonymized, but you can see here that actually this is the before, and then after it's reduced dramatically for every single one of those except this person, and this is an unusual one, but I left it for the purpose not to show that I'm too efficient. So in this kind of patient cohort, we're looking at a 63% reduction of GP appointments for non-clinical needs, which I think is quite significant. Now, if you're not part of a dietitian team, which is traditionally how we work, are there any benefits to being a PCN dietitian? And I would say yes, there is. So we have full access to GP records, no more writing letters to the GP anymore. We have full access to all hospital letters sent to the GP, no matter from which hospital they're sent. I have access to an on-call GP every single day because often when I'm talking with people who have frailty, if their clinical need has changed, I can arrange for a GP review right then and there, and that will be done on the same day. So I'm not having to leave that to someone else to do. I can arrange for that on the same day. We have access to all of the primary care staff, so all of those clinical staff, but also all of those non-clinical staff, which is really key in kind of supporting a patient to keep them as healthy as possible. There's also an electronic footprint of all requests, which is my favorite part. So it means if I ask for a medication review, it gets done. There's no more pretending they haven't seen my written request because it's electronically all saved to the patient records that I've asked for all of these things. So everything we kind of ask for gets done. There's access to prescriptions, so you can look at whether prescriptions are being issued, for example. Often patients will say they've been having this supplement every day for the last 3 months, but actually when you go on the record, it's not been issued for that long. So you know that there's something not happening there. I can also initiate ONS prescriptions, so I don't have to ask the GP to do that prescription for me. I can initiate the prescription, and the GP will sign it off for me. There's also the opportunity to upskill and work at a very high clinical level. Again, this will be very varied depending on your PCN and what the needs are, but the opportunities are there. The funding is there. Primary care has a lot of money. So I think, if it's something that you are considering, then, and if you're on a very specialist role at the moment, the opportunity to diversify is there and the funding is there. And I think there's definitely true MDT work in a way that I've never really experienced in secondary care before. So here, every single week, we all turn up to our MDT, and we can all discuss our patients, and other people who are in that room will pick up patients. So sometimes they'll talk about a patient saying, they've got constipation, and then they forget that I'm here, and I can actually help to kind of address that. And I'll say, I'll have a word with the patient, and that patient will come into me, and then I can help resolve some of that issue. So it's a very nice way of working. And I think there's also autonomy and opportunity to build services from the ground up. So if you like that kind of challenge, you want to be able to build something from the start that's very patient-focused, really patient-centered, then I think primary care has got amazing opportunities, and it's very open actually to kind of having dietitians. And in a lot of kind of for GP surgeries, they don't refer to dietetics. And one of the reasons is, yes, there's no access, it might not be commissioned services, but also if a service rejects enough referrals, the referrers stop referring because it's not really worth their time to fill out the form when they have 10 minutes to see a patient, diagnose the patient, manage the patient, and then do the consultation, write it up, and do a referral. So this is what we find that does happen, especially in the West Midlands, that because of high rates of rejection, a lot of surgeries don't even bother referring. So the GPs were kind of taking on this burden themselves when they're not really the most trained person. But I can appreciate why they were doing that. Are there challenges? Yes. So clinical rooms are a massive challenge. I started in the pandemic, so I was fully remote, and I'm still fully remote. But one of the main reasons why they asked me to be remote is because there wasn't enough clinical rooms available. And actually, it turned out I do really like being remote now, so I'm not going back. Some teams are resistant to the ARS staff. So PCNs are fairly new. So effectively with the PCN, the surgeries are learning to work with each other, but now they have this additional group of staff to kind of also learn to work with. So it feels personal sometimes when there's a bit of resistance, but it's not personal. It's just a new way of working, and it will take time. But I've been working in this role for 15 months now, and I think there's been massive change in attitude in that very short time. So I think it's definitely changing. Expectation of surgeries can be misguided. So often they, for example, we've noticed with the first contact practitioner physiotherapist role. So with the ARS funding for dietitian, it just says dietitian. So that means the dietitian can be employed to do a PCN work, or they can be employed to do an SCP dietitian role. But with the physiotherapist, it's only for an SCP physiotherapist. So a lot of surgeries signed up for the physiotherapist thinking, oh, we have a physiotherapist in-house now to kind of deliver treatment. But that's not what they do. It is a first contact role, and then they will see the patient, assess them, diagnose them, and then refer them on to traditional community services. So I think the expectation sometimes can be misguided, but conversation is the key. There are different surgeries with the PCN. They all operate differently. So usernames are different, passwords are different. The way you do onwards referrals are different. So it is quite a lot of things to kind of remember all the time, especially if you're working across multiple surgeries. So I cover 7, and often I'm logging in and out of different ones during the day. So that can be a little bit tiring sometimes. And there is lots of new systems with hundreds of passwords. So that is definitely a flaw in the system. And I think some services are looking to kind of integrate that, but at the moment that's not fully there. And it can actually be quite lonely if you're used to working in a very kind of traditional setting, because it's a new way of working. I really like it, it really suits me, but I think that's to be mindful of, that it's not for everybody. So some advice if you're starting out. I think, like Vari said earlier, prepare. And I think this is true for this role. If you started a role like this, don't jump into seeing patients straight away. And that's what I did. And in retrospect, I think that wasn't the correct strategy. I think really take your time to prepare, learn the system, learn the software, scope out the area, what's already available. Like I was told there was no access for people who were overweight and obese, had obesity, and they couldn't be sent anywhere. But actually, there was a really brilliant service that not only looks at nutrition, but provides physical education, cooking classes, they provide the patient with holistic health coaches, so the patient's accountable to somebody. And this was out there already, but the surgeons didn't know about it. So I think it's really important to take your time, scope out the area, find out what's available. If a patient's better managed by end of the team, don't feel like you need to keep them on, refer them onwards. And I think really if you put patient care at the forefront of what you do and dare to do things differently, like everyone here has been today, you can't go wrong. You need to find your why. And I think for us here today, it is about providing really great patient experience and then putting patients at the forefront of what we do. Then there's no way you can do anything wrong. Take risks. There's no learning when you're in a comfortable place. So today's very scary for me, but I'm taking the risk. Don't be scared by the possibility of failure. Even if there is failure, that is where you're doing learning. And often when things just go well for you, you've never learned anything because you've just gone well and you've not thought about it. So I think, don't be scared, take your risk. The way we've always done things is not appropriate. The NHS isn't coping with that, and we need to have change, and we need to not be scared to be that change ourselves. And the other thing, I think, if you're starting out in a PCN role is actually identify what your learning needs are. And this would often be what is the need of the PCN. So, an upskill, there's time for that. CMPA is a big one, a big burden on GPs. It sounds really scary. I've never worked with pediatrics before and I didn't want to, but now I do it and I do it very confidently. So naturally the Nutricia Academy has an amazing learning module on it, which is one I did when I started. So that's something to be very mindful of. Eating disorders, not to treat, but to be aware. I recently learned about binge eating disorder a few months ago, and I didn't really know about the complexity of that. And actually, many patients were coming to me with referral that said, patient can't stop eating, please give healthy eating advice. And actually, they had an undiagnosed eating disorder, which needs to go to the eating disorder team. Fussy eating, again, not to kind of treat, but also just to be aware. Nutrition support and frailty is a big part of primary care network work. IBS and diabetes also. And I think lastly, it's just really important to know that you are one person and you can't do it all, and I feel like because we all kind of, we want to help people, we take on lots of work sometimes, but don't be scared to help, to refer people onwards, and actually that you can't do everything, there's only one of you. So that may mean that we ask for additional funding for additional dietitians, which there is lots of in primary care, but there's not enough dietitians, everyone's struggling with hiring at the moment. And I think, this job is really interesting because there's breadth and depth of everything that we do. So you need to be aware of lots of things, but also being able to then signpost or treat or refer onwards to the appropriate team at the same time. So hopefully that was an exciting summary of what PCN Dietitians is about and what we do. And I'm really hoping that you all want to become PCN Dietitians now. I am recruiting, by the way, if anybody's interested. Thank you so much. Does anyone have any questions?
Thank you so much, Kayennat, for sharing all of your experience to date and the challenges along the way as well, and being honest about, the loneliness that you sometimes experience. I think the value of MDT working and building the rapport within the team hopefully makes up for the fact that you're not surrounded by a team of dietitians, but it sounds like you will be surrounded by a team of dietitians if you go on in the vein that you are, because hopefully you've got foot through the door and access to funding potentially to allow that these posts to grow really, and they'll no doubt grow through better understanding of the primary healthcare team in appreciating what we can offer. So thanks for that. Are there any questions from the audience? Okay, I can see one over here, mid. Am I right? Thank you.
Hi, my name's Gerald Alvarez. I'm a PCN dietitian in Hackney, city in Hackney. And I was a PCN dietitian before as well, so I've been doing it for about 18 months now. Everything you just said is exactly the experience I've had as well. So it's refreshing to hear sort of other people's experiences. I'm really struggling with the FCP side of things because GPs don't really understand it, and they're quite wary of us kind of going into that. And I think they're a bit worried. I think specifically with gastro, in terms of the risks. I'm just wondering if you've had any pushback at all generally, and if you had any advice.
So it's not something that we're doing at all at the moment, and that's one of the main reasons. GPs said they want to see how the other FCP physiotherapist, podiatrist and paramedic role develops, because they were quite confused about what it is. They've hired all of these staff and then actually didn't know that this isn't what they do. So I think for us, it's just not a priority at all at the moment. I think in some of from what you mentioned, I think talking to your clinical director is key. If your clinical director is on board and they understand and will support you, then they will kind of filter that message through. But if they're not on board, then it's a very hard battle. So no, I don't have any advice, I'm sorry.
I suppose the other thing is as well is I'm trying to, not everyone understands our role, I think we all know that, but it's trying to convey that, when you've got basically five different businesses that you're trying to work with, and it's quite difficult to sort of keep going back and doing training all of the time, to sort of explain what we do and how we work. Have you done anything like that at all, or were they fairly kind of knowledgeable already?
I think for me, because in Dudley there was a very patchy access to dietitians, so everyone was just grateful that I turned up. So I think they did leave me to it. There was an amazing amount of trust actually placed in me, and nobody was kind of micromanaging me or asking me how many patients are you seeing in a day or blah blah blah. So I think for me, my clinical director was very on board in having a dietitian. She knew what a dietitian does, and she really appreciated the value of what we do. So I think that is definitely the key. So a part of our role, and I didn't mention this, but a lot of it is education of not only what a dietitian does in the historic context, but also what we can potentially do. So I think if you want to attend one of the PCN meetings and put together like a little presentation to present and ask them to kind of give you questions. I struggled getting enough referrals when I first started. because my clinical director worked for one surgery who loved me, but then the other surgeries were kind of like, oh, a dietitian, another service that's going to reject our referral, so I'm not going to refer anyone to her. And I thought it was a bit odd because I wasn't getting as many referrals as I thought in the first 2 months. So I actually had to go visit every single surgery, have meetings, and really talk to the team to understand what their hesitancy was, what the barriers were, and through open and honest dialogue, that it came out what their concerns were. And then I, put things in place to kind of address all of those. And now I think we have a really good working relationship. So it's really taking the time to just talk to people in a way to understand, not to teach almost. Does that make sense?
Thank you.
Thank you.
Yeah, and I think, when you look sort of 10 years ago, really, when we first started talking about access to dietitians, I know Nutricia did some focus groups in the community, and a lot of GPs were saying at the time, it was horrifying to read, they were saying, I have no idea what my local dietitians do. I refer, my patients wait months, it's all a pointless service, so therefore I'll use my nurse and my pharmacist. Yeah. It was devastating to hear, because that's sort of ignorance around the role and not opening up those conversations. And I think times have changed, I think, because of the shortage of GPs, they can't carry on doing what they're doing. So yeah, I think, now the time's ripe now. Sorry, I'm dominating the microphone here. Question at the front here.
Can I just add something to your question? Sorry. So one of the surgeries were adamant they have no patients at all that require a dietitian. So a relatively small practice of 2,000 patients. However, I thought it was a bit odd that not one of those 2,000 patients required me, or the podiatrist, or the OT, or the health and wellbeing coach, or the social prescriber, or the pharmacist. So what I did was I did a search. We use EMIS, so I did a search of all the patients who were malnourished with a MUST score of BMI of less than 20. And actually they had 200 patients. So I emailed that list to the surgery and said, actually, this is, there's evidence here that your patient do require onward support. And they were like, oh, we've never thought about this before, and now they refer regularly. So if you have the time and the ability to be able to do searches to kind of actually demonstrate that these patient group I could really work with, then that's also there.
Hiya. It was really, really interesting to hear that, and it's very heartwarming that you've had a good experience. I was a PCN dietitian for about 15 months as well, and I think every single point that you said there, I could have said the opposite. So I didn't have any understanding of what the role was, no interest in me developing anything. I wasn't given any time to speak to anyone else. I was told that communicating with the community dietetics team was a waste of time, and I could be seeing a patient at that point. I arrived on day one with a full clinic list. I had no idea what services were available and was given no time to figure out what services were available in the area. So completely opposite. Yeah. And finally, completely, for me, pointless. It was too overwhelming, the task of trying to turn that ship around. Yeah. But it was also a time when it is brand new. These are, we are the people who are kind of trailblazing in a way and have those fights to fight. And it was before the roadmap came out as well. And I'm just wondering, now that, you mentioned you're recruiting and kind of looking at job descriptions and role outlines and so on, do you find that roadmap is helpful? Do you think that feeds into it at all? Or do you prefer the sort of general PCN dietitian? As you say, you're a specialist generalist, and that's where you see the role? Yeah, so I think the roadmap is a great opportunity for people who want to improve their clinical practice. It's not something that I'm personally interested in. I'm happy to kind of stay in my general specialist role. But I think if we have people who want to do that, we will support them to go through it. But in Dudley, because of the lack of access to dietitians, the surgeries, and it does come down to what the surgeries do want and need, and often it is based on the clinical director's kind of authority almost. So if they've said no to the roadmap, then that's not going to happen. So you do need your PCN, your clinical director, to sign you off, approve you for the kind of leave, and you need their permission almost as well to do the kind of some of the extra training, like the non-medical prescribing, and so on and so forth. So I completely understand, and I think had I had a different clinical director, then maybe my experience would probably be more similar to yours. I basically didn't have one. Oh gosh, okay. Managed us or met with us or did anything. It was not the best experience, but it is really good to hear that you have had a good experience and that you also similarly have had a good experience. So I think we need to draw on that, and support other areas to see the positives and see the great work that you've done. Thank you.
And I hope actually the British Dietetic Association will have, I mean, there's a PCN sort of network at the moment, isn't there? Primary dietitians network.
Yeah.
There's a bit of a stall in terms of setting up a new specialist group because of the pressures in head office. But I think, that would really help with the communication and sharing of practices to actually have that a formal professional group. So it'd be nice to see that developing. Okay.
Thank you so much.
Oh, there's just one very quick question at the back there, if you don't mind. Yeah.
Hello, it's Long from Surrey University again. My question is almost like a follow-up from that question is, do you think it's suitable for a newly qualified dietitian? Obviously, in the beginning you said it's higher level 7. If not, since you are quite struggling with recruitment, is it possible to offer as a progressive role, as in you fully support and to develop someone into that role?
I think that's a great question. I have seen some of these roles advertised as a band 5, and I think that's highly, highly inappropriate, even though I don't like the word inappropriate. It's highly inappropriate for a band 5 to be doing this work. It is a high level of clinical practice. In terms of supporting a person at a band 5 or a band 6 to progress, it's quite hard to do because as much as the 6 PCN in Dudley, right, and we want to have a dietitian in all of one of those, we can kind of provide clinical supervision, but not to that degree that would be to help someone who doesn't have the relevant experience. And they don't have to have experience in primary care. They just need to have really, good experience working in acute community or a blend or whatever, and that would be fine. But we don't have that kind of infrastructure because we're not technically a dietetic team. So at the moment it's a team 2. We do meet once a month for meeting and we provide supervision to each other. But to actually be able to, on a day-to-day level, help someone to manage any challenges coming through, it would be incredibly, incredibly difficult. So it's not something that we were looking at to do at the moment. I think we would be happy to look at a band 6 who are very experienced to then help them progress to become a band 7. That would be definitely doable. But from a band 5 to a 6, no, I don't think so. Thank you.
Okay. I'm afraid we're going to have to move on. So are you going to be here? One quick question there on the left. I'm just conscious we need to keep to time. So.
Thank you. I'd be interested to know your experience in how receptive your PCNs are to taking student dietitians, because we're trying to increase the number of placements we offer, but the PCNs are reluctant to let them go out into the work with the band 7 diet and primary care. So I was wondering if that's anyone else's experience. Yeah, so in Dudley we've done things very differently to other PCNs, is that there's a separate trust that's been formed to hire all of the additional reimbursement scheme staff to then provide services in the PCN. So while we work for the PCN, we're not directly employed by the PCN. So for us, it's actually a little bit even harder because we've got governance from our trust to kind of manage, but also then the PCN's own level of governance and then the rest of it and the risks. So we've asked about students. They said no. So that's not going to happen in the near future. There is a team working on it because there's such a massive need for student placements, and it's something that we do want to help and support. But at the moment, because the governance is not in place and the structure is not in place, and we don't want to put students in a situation where they feel unsupported and it's not the best learning environment, especially if you're in PCNs where they're not even supportive of a dietitian in the first place. So we want to be able to make sure that support is there. So I think once our trust has that structure in place, then it'll be easier to kind of put through. So they are working with the physiotherapist as well and the dietitians and the OT to kind of see what we can do about it. So
I actually think there was one element that they did consider, which was she'd have students to do sort of smaller projects and audits, so to perhaps do it that way rather than clinical experience. I think the perception is that it'll take the dietitians away from doing PCN work, but we've tried to say there's work that the students could do while they're also out there, not just that they're there to shadow and watch. But so
if it's part of the job description, then that's an easier way of getting around it. I do find that PCNs, if they're not part of a separate trust, they tend to be a bit la-di-da about certain things. So they'll just do things without the governance and structure in place. So for example, for us, some of the non-clinical members were being allowed to give patients lists from the houses to hospital or medical appointments. and no one had ever thought about the safety or the risk or of that. And actually, really horrifyingly, one of the non-clinical staff was attacked by a patient who had delirium, and so now, since that incident, they've decided that needs to be stopped. But it was things that we would never put ourselves in the situation, but they were allowing other non-clinical members who's actually not worked in the NHS before to do some of these things because they thought it's helping the patient out, which it is, but it's not appropriate. So I think, there's a lot of risks involved, and we really need to look at those more closely.
They asked for it to be taken out of the job descriptions, but didn't notice I didn't. So student training's still in.
Thank you, everyone.
Okay, thank you very much, Kayennat, for that enlightening insight.